Anim, bonjour. Hello, everyone. Welcome to today's peer sharing and learning session, Improving the Primary Care System in Your Local Community, How to Stage the Work. For those of you I have not met, my name is Leslie McGill. I am a focal point and coach with RISE supporting primary care improvement. We encourage you all to introduce yourselves, your organization, or your OHT or PCN in the chat box as we get started today. For those of you who have not had the opportunity to join some of our previous sessions, we just want to call up here on the slide that there is an online shared space where our past session where we talked about orientation to improving your local primary care system, the deck and the presentation recording are both available, as well as many other resources. So for those of you that are familiar with RISE supports and participated in our population health management supports, well, those online groups are no longer available. We did post all the resources, the many helpful examples that you shared in this same OHT shared space. And Steve will post that link for you all in the chat box so that you can sign up. Also want to call it as well that Ontario Health has a very helpful PCN knowledge exchange hub for all of you who are operationalizing PCNs. There's some very helpful resources for you there as well. So please continue to introduce yourselves in the chat box. For those of you who are new to RISE, we are a free support for OHTs and PCNs as they develop and mature. So we look forward to getting to know all of you. With that, I am going to pass it over to our co-lead at RISE, Dr. Rob Reid, to provide today's land acknowledgement. Rob.
Yeah, so nice to meet everybody. I think I've met many of you here. I'm Rob Reid from the University of Toronto and Trillium Health Partner, and I co-lead RISE with colleagues from McMaster and NOSM. And as we meet today here in very smoky Ontario, we're in solidarity with the Indigenous people of Turtle Island and would like to begin by acknowledging the land on which we gather as part of the treaty lands and territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, the Huron, and the Wendat. And we also acknowledge many First Nations, Inuit, Métis people who call this area their home. We're very grateful for the opportunity to be working on this land. Thanks very much, and back to you, Leslie.
And I'm actually going to pass it over to Mike. I just want to, yep.
Okay, welcome everyone. Good to see you all. I'm Mike Hindmarsh. I'm the lead coach at RISE, and just the objectives for today is to help you understand how to think about staging some of this work. There's lots of work that needs to be done. Some people will start in some places, others will start in different places, but we wanted to go through an example today of how one of the OHTs has staged a lot of this work. So after this session today, 1 week from now, we'll have a problem-solving session where we will come together again and talk about the issues around staging, what's working, what's not working, and have you all sort of solve your own problems along with the help of some of our expert speakers today. Next slide. So just so you know, RISE has been asked by OH to pivot a little bit in the work that we're doing. We're going to be focusing more on supporting PCNs, the development of effective PCN leadership, as well as how can PCNs recruit primary care into the PCN so that the work around improving primary care can be done more effectively. We don't have a session in August. Right now, we have a placeholder in September for looking at PCN development and engaging primary care in October. We're working on those sessions right now and getting some expertise around PCN leadership. This doesn't mean that we're moving away completely from the work that we're currently doing, but we're looking at how can we help the PCNs partner with OHTs to more effectively do this work. Next slide. So just a quick recap of what we've talked about at the last session, as well as what we talked about in January, March, or January, February, and March. And what we're trying to do is improve the primary care system by making sure that it's continuous, collaborative, all of the qualities that you see on the left-hand side. And to get to that, we need to be doing work that includes the drivers that are on the right-hand side, interprofessional team-based care. Many of you are working on that now. How do we make sure that there's continuity, that patients see the same team or the same providers? How do we make sure they have timely access to care, especially as we begin or continue to attach patients to primary care? Making sure that we have population health management approach so that in primary care they understand not only the individual patient, but they understand their populations of patients and how to better manage them. And clearly, we need patient partnership and community engagement. A lot of you have done great work around patient partnership. Performance and measurement. We have the measurement that certainly comes from the province, but we'll also need to do measurement internally, and especially within primary care when looking at changing the care for populations of patients. Looking at leadership and accountability, and we're partnering with people like Align and others to talk about leadership and accountability. And then digital health, of course, which is going to be critical to supporting all of the drivers and the key changes that we need to have in primary care. The goal of all of this is to address the quintuple aim, and that is provider satisfaction in delivering care, improve patient experience, improve effectiveness, efficiencies, and cost, population health management, and making sure that everyone has equal access to the improved care. Next slide. So when we think about how we're going to get started, one of the things you can do is start thinking about convening a focused group of people that are going to work on primary care improvement. It could be PCN leadership with OHT leadership. It could be primary care working groups, but you want to put together a group of people whose job it is to start thinking about how are we going to make changes to our primary care system to better deliver care. You want to leverage evidence-based tools and approaches, which again, RISE has lots of information around that and lots of resources that we can help with. So depending on where you want to start, there really is no wrong place. You can start with your TPA deliverables. You can start with things that you're doing well and do even better at them. You can start with your challenges, or you can start sorry, my screen's so small I can't even see. You can start with the particular objectives that you want to try and achieve in primary care. So next slide, please. So when we think about staging, it can happen a variety of ways. It can be a sequential process like the one laid out on the top. Is there trust between primary care and the rest of the system? Maybe what you want to start doing is building your interprofessional team-based care, making sure that everyone is not functioning in silos, but is actually functioning as a team and have clear roles and responsibilities. That may lead to ensuring that patients see the same provider. That's a relational continuity piece, and that is either see the same provider or the same provider team. And ultimately, as you attach patients, it might be an issue for you to make sure that there's timely access to care. So how do you ensure that the rapid attachment doesn't have a negative impact on access? So that's an example of how you could do it sequentially. Quite often, it's done as a parallel process. So again, if we're looking at this trust between primary care and the rest of the system, you may find that you need to do relational continuity first, along with timely access to care, which will lead to interprofessional team-based care and a more population health management approach. So the point of this slide is really to say, you need to figure out where the best place is to start. We can certainly provide guidance on that, and you'll see an example from Kuching today of how they tackled that. I think the important takeaway here is that you've got to remember that it's the drivers that you're working on to create that improved system with all of those attributes attributes that we saw on the previous slide. Where you start can depend on a variety of factors, and we can certainly advise along that line. Next slide. So one of the questions, or some of the questions to consider when you're prioritizing which drivers and where to begin is which drivers are closely connected. So, for example, attaching patients and access are obviously very closely connected. Building team-based care and making sure that there's relational continuity with patients are often closely connected. So think about those drivers that are closely connected and that you'll probably work on together. Which drivers help you build team capacity, but help you reduce waste or inefficient referral processes? What are the enablers that you need to do the core jobs? You need better chronic illness care, providing access, attaching, so on and so forth. Which drivers can be done together? Which ones align with your accountabilities, which a lot of you are probably focused on at this point, your TPA deliverables? Which ones are connected to funding opportunities? What work is going well and are strengths that you can build on? What's not going so well and there's opportunities for improvement? And where are you right now in this work? Is there anything you need to go back to and reinforce? Is there anything you might want to redo now that you have a better sense of the work that needs to be done? What are quick wins versus long-term work? And I think that's very important for teams to have those quick wins so that they get a sense that they truly can change the system and be successful. So those are some of the questions to consider. Next slide, please. So I want to introduce our team that's going to present today on the work and how they approached improving the primary care system. We have Dr. Kim McIntosh, a family physician and is a co-lead at the Couchiching Ontario Health Team. She's Chief of Staff at OSMH, which I should know what that means, but I don't, Kim. I apologize. And we have Lori Webel-Edger, a nurse who is also the primary care collaborative lead and with the Couchiching Ontario Health Team. They're going to talk to us today about how do you go about staging this work? How do you we're going to break it in two, just so you know. They're going to talk about how they approach this work, and then we're going to have a breakout where we will go into rooms and we will talk about if we were Couchiching, what would we do next? And then we'll come back and we'll hear from Couchiching what they did do next. And so hopefully this learning opportunity will give you a sense of where you might want to start. So with that, I believe I'm handing it over to Kim and Lori.
Thanks, Mike. I'm going to kick us off. If you could go to the next slide, please. So Couchiching Ontario Health Team is one of the small-ish OHTs. We are part of the Central Region, and we cover the city of Orillia, the townships of Severn and Ramera, as well as the northern part of Oro-Medonte and Rama First Nation. We have an attributed population of 63,000 and a geographical population of approximately 100,000 with a combination of both anchor partners and affiliate partners that support our collaborative work. If you go to the next slide, please. So for our population of 100,000, we have three main postal codes that we cover, and our population is on average a little bit older than most of Ontario and has a little bit higher rate of population change happening. About 1 in 10 people in our area are unattached. And from a priority populations perspective, we are dealing with individuals with heart failure, COPD, and mental health and addictions. If you could go to the next slide, please. We do use the Ontario Marginalization Index to help inform our attachment plans and our equity work at the local level. Most of you who are in the OHT world are familiar with this in indices, and you know that the least marginalized is D1, and most marginalized is in D10. And you can see this middle area, which is our highest populated postal code area. We have large areas or a higher percentage of individuals with needs across a number of different domains. If you could go to the next slide, please. So our primary care network is a bit unique in the province. We have over 300 members, and we are a multidisciplinary primary care network. You can see on the left-hand side of the spaghetti map of all the different organizations and provider groups that are involved. And we are composed of community paramedics, family physicians, midwives, nurse practitioners, and pharmacists. And we have over 300 individuals that are actively receiving communication about our primary care network initiatives. If you go to the next slide, please. And this visual really kind of gives you a sense of the governance in our OHT. So we have the Joint Executive Committee or team in the middle, which is bookended by both our primary care network and our patient family caregiver network. And this visual kind of helps to show that both groups are equally important to our population health work and all of our collaborative conversations. And the light green are the various working groups and tables that are supporting all of this work as well. So if you go to the next slide. So following round 0 of the IPCT work, we were able to, within Koochiching, address some of those gaps with our unattached clinic, and by opening up the family health team services to all in the area, we're able to have this comprehensive health home neighborhood that was supporting both the patients in our area as well as the provider group. So you can see on the left side is all of the different types of services that are available within this health home. And then on the right side, you see all of the different providers that are involved in supporting that comprehensive team of providers in our community. So if you go to the next slide, I think I'm passing it over to Kim.
I'll grab the baton. Thank you so much, everyone. The Koochiching Ontario Health Team really had relationships and an integrated care model that predates calling it an Ontario Health Team. So that is very advantageous. And in February 2019, we had everyone please come to one room. That was pre-pandemic when we would have large gatherings, and we literally all coalesced around a shared purpose, and that created the successful approval of the Koochiching OHT in the first round. Many of those relationships galvanized through COVID response, and I'll talk to that in the next timeline, which is our primary care network. We started, of course, strategic plan and that idea of branding. We added more partners, as you saw from all those bubbles. That version of governance has gone through many, many iterations. It is all about shared purpose. It still is. And you can see as we traverse along our timeline for our OHT, we did receive, as Lori mentioned, primary care interprofessional team funding, and that enabled us to expand really the core of our health and wellness home, which is the family health team, so allied service for all. We were then recognized as an accelerated OHT, 2 in each region, which, as you may recall, created some consternation, the haves and have-nots. Koochiching took it very seriously to show what is scalable, what is the art of the possible, what can be stamped out around the province in terms of expanding and integrating care and ensuring you had provider and clinician wellness across all team members. We grew our OHT with more local partnerships, and this is across municipalities, individuals, social services, private care entities, you name it, they're involved. And our medium-sized hospital, our family health team, we successfully implemented our chronic disease hub in 2024. And then fall 2024, you may recall, there started to be more of a focus on attachment, connection, access. And there was movement toward PCAT was coming into its formation. We created more strong partnerships with our local recruitment entity. We're going to need more family docs recruited. We're going to need more everyone recruited into our community. And how do we build a team without leaning into more of our local partners? We not only do we need to lift our team, we need to find the people who need the care. It's one thing to have postal codes and a geography and population health as a vision. We created our own unattached wait list, which I know many regions did. And I'll stop there because there's a deliberate cutoff. There's going to be more discussion about the timeline after the breakout groups. So I'll pause there because next would be, of course, how do you create and negotiate with Healthcare Connect? So I'll pause on that one. Concurrently, so we're always doing two things at once. We're building an Ontario Health team, we're building a primary care network, and we are all concurrently trying to make sure our providers and clinicians okay, do they have what they need? And big capital and, do our patients, families, and caregivers have what they need? Are we truly co-designing? So our primary care network started as a few family docs fighting the good fight in pandemic response. And we grew that group and we became multidisciplinary very quickly out of necessity. Like I needed to call a pharmacist to figure out how to get Paxlovid out into community in the early days when it was a very restricted access, as an example. We grew our primary care council because that was where we could start with leadership. You start with that core nugget of those individuals who really truly want to have better outcomes for their patients and their community members and support each other. And then with that primary care council that grew, we created terms of reference that has gone under several revisions, but it's really held us to that core hub of leadership. And from that point, we could then grow out to be really foundational. I'll point out March 2023, I tried for a physician association. It was a fail. 85 docs come out and then sign up on the dotted line and 3 emails come back. So drop that one. There's as you asked Mike, the good and the bad, and the learning opportunities. So moving along our timeline, we spring of 2023 and moving in. So Jet into October, I asked Jet to approve another primary care voting seat. Remember those bubbles? The book ended with patients, families, caregivers, and primary care network. But then how are we represented? If primary care is 90% of care, where do we sit in relation to all the other partners who have boards, who are incorporated? We're not incorporated as a primary care network, nor will we be, and that's okay. But more and more you see the growth through the OHT maturity and the PCN maturity, and it starts to become, the PCN is foundational, it's operational, it needs to be all things to all people. OHT KPI deliverables and TPA deliverables and KPIs are now looking more like what is access and attachment? How do patients get care? How do we get more family doctors in teams doing the hard work of comprehensive family medicine? So we moved our primary care network through these phases of maturity. We continue to grow our leadership model, really focused on dyad leadership. And you see our leadership council continued. Sorry if I froze there for a sec. It was all about, over time, growing what needed to be a governance model that would enable us all to do our best work collaboratively, both as an OHT and a network. And I tend not to distinguish the two because they are really so interconnected for population health. Our dyad leadership model has become absolutely paramount. Now, rolling into 2025, I'll pause there because that's going to be the summation of where we went next after we all troubleshoot these levels of maturity. So back to primary care system drivers and substrates. And I'll just point out, this is an OHT slide that is all about primary care system drivers and substrates. I think that's important to highlight. So all of the drivers are true, you know them to be, the trust, addressing inequities, and that's intra and intertrust. There's has to be trust amongst an interdisciplinary primary care network writ large, and trust outward toward patients, families, caregivers, and outward toward other partners. And we had that legacy of trust. So as I'm sure many of you recognize as a key enabler for anything we do in healthcare together. And I'll let you read through the slide. There are opportunities listed. We'll go to the next slide because the list continues related to where can we link these substrates drivers to what we do and what we need to do next. Because, trust and good intentions and shared purpose can only get you so far. You actually need to start measuring, start reinforcing relationships so that they will meet the outcomes that you are now measuring. And that's where a primary care network and an Ontario Health team need to be matured and probably consolidated to some degree in terms of how can we stamp out an actual functioning team where your providers are happy, you have recruitment and retention, patients have access, connection, attachment, and we can measure all those things. And now we're going to, I think, next slide. I think we get to do some breakout sessions to have discussions about some of this maturity modeling going forward.
Thanks so much, Kim. You'll see in a minute that we have the audience broken up into regions. Please go into the breakout group that best represents your region. And the discussion here is really about if you were Couchiching, what work would you prioritize next? And why would you prioritize that? How would you think about staging your work? As I listened to Kim and Lori, the takeaway for me was all the foundational work that they did to get ready to do the work of that we talk about in the drivers and improving primary care, the creation of the primary care network early on, recruiting primary care providers early on and getting them organized and understanding what the message was around the work that needs to be done. So I think that foundational work was really what I took away from everything they've done. And I would suggest that when you go into your working group, what do you think would happen next? What do you think Couchiching should work on next and prioritize? So Leslie, I'm going to let you put people in rooms or tell them what to do.
Okay, Steve is actually going to do that for us today. So there will be a RISE facilitator in each of the regional rooms. And that lovely slide, or 2 slides that Kim just walked us through with what's working well and where they have opportunities for improvement, we'll have a summary posted in our rooms so that as you think about what you think they should work on next and why, that will be there for your reference. So as we wait for everybody to get back in, and Mike, I'm not sure if you're back yet.
I am.
Oh, wonderful. So I'll pass it over back to you.
Okay. So lots of great conversation in our session. What I'd like all of you to do is think about what are the key sort of staging considerations, or where would you go next, that came out of the conversation in your particular group, and it may be, where do you start? So our group talked a lot about where do you actually start and what's important there. But what staging considerations came out, and just a quick reason why. And what I'm going to do is give you about 30 seconds to think about that from your group, and then we're going to do what's a chatterfall. I'll say go, and all of you type it in to the chat box, and we'll just see what comes up. We won't go through it. We will collate it and summarize it because we don't have time to go through it all. But so let's say we'll give you 10 more seconds, and I would say 6, 5, 4, 3, 2, 1. Type your responses in and let's go. Brenda wins for getting in first. Terrific. Great stuff coming through. Wonderful.
I hope we get a copy of this, Mike.
You will. Yeah.
Thank you.
Yeah. Terrific. This is great. Okay. Keep typing it in. And what I'd like to do is hand it back to, keep going with entering. I'd like to hand it back to Kim and Lori to talk about what they actually did.
Sure. Thanks, Mike. If you could go to the next slide, that'd be great. So one important step that we took to inform our attachment strategy work was to conduct a situational assessment. So in this step, I did outreach to all of our different PCN membership groups to gather their thoughts on challenges and opportunities as it related to additional attachment. And there were some great information and lots of common challenges across the groups. And that led us to develop some strategic recommendations for our primary care network. So, focusing on enhancing the provider wellness and retention, expanding those clinical services, improving our collaboration and communication, continuing our work on health equity, and really kind of strengthening that system integration work. So this step really was critical to continue to build those relationships across, and to understand, as I mentioned, the priorities for the primary care network. So if you go to the next slide, please. Thanks. And concurrently, while that situational assessment was happening, we were really intentional about trying to articulate what the primary care network was, and how that return on investment, what that return on investment was for providers, if they were engaging in any of the primary care related initiatives. So we really tried to show our members what was in it for them, and that return on investment. So really being able to articulate through this, we call this our PCN placemat, that they do have a voice in that collective decision making, and that that the digital strategy work is about supporting them. So, and helping them to see kind of where those funding opportunities were and how that work was coming together to enhance that patient experience. So if you go to the next slide, I think I'm handing it over to Kim.
Yes, so I'm looking at the time. This has been a really important visual, and I reference it often. It reflects how patients, families, caregivers, and providers and clinicians can interact with our primary care continuum, because it's bi-directional, depends on where people get care. It's the right place, the right care in the right place. Next slide. Here's the continuing story of our timeline. We added in our additional steps. Thank you for the breakout rooms and the troubleshooting. Absolutely going to review those notes. Talked about Healthcare Connect. We have a family medicine teaching unit, so endeavoring to train up family physicians into our team. Support attachment initiative. We've run that, and we've been very deliberate about definitions. Colleen mentioned that. Definitions are so important, and being consistent with what are you intending to do, what will it do for your providers, and how does that get measured. Our interdisciplinary primary care team, third round, we weren't eligible for second round. Third round approved. Now we get to, okay, now what? How are we going to attach everyone and contextually? So we've got that work to do. And we've had ProDoc expansion. So Practice Ready Ontario, great program. Highly recommend for all of you to consider to expand the family physicians in your team, particularly in your underserved regions. Next slide. So I'll just continue us along from January onward, increasing our opportunity to have funded, supported dyad leadership. Can't highlight that enough. Lori is a collaborative lead, and myself, our digital lead, Dr. Farn, and our digital lead for the OHT PCN. We presented Marilyn Crabtree on this call. Nicole Nitty and I presented at the Provincial Action Summit. There's the next one coming up November. I'll plug for that. The OHT PCN Action Summit, and we presented on maturity models of primary care networks. So continuing the work of, we can articulate this and create what we need to see for our networks and our respective communities. And we did some significant leadership review, focusing on our terms of reference now for our PCN. We were missing that. We need it. And an MOU, most importantly, an MOU between the OHT and the PCN to really hammer home the point of PCN, primary care network, is both the foundational governance modeling for care delivery, and it's the operational. We can be both. A well-formed primary care network with OHT supports from partners can truly do all the things. I strongly believe that. Next slide.
We'll have to really speed through this.
I'm done. I'll show it. Here's the phased approach. I've spoken to it already. Trying to put this into the columns to be more strategic and be able to say we've measured this. To answer Dave Pearson's question about how do you measure integrated primary care? Gosh, really trying and focusing on a phased approach that will all feed into our health and wellness home, which is our gold standard, and really where we all want to be for our population, so that our patients can get the care they need, when they need it, where they need it, from happy providers and a team. The other important point, fit services for all, that's our hub. We have fit services for all. It doesn't matter what the doc is, whether they're faux doc, a fee-for-service doc, we don't care. Fit services for all, this was an enabler. Then you add the family docs into the mix and say, what would it take They say, oh, I need some extra support, a nurse, I need a central this or that. Great, fantastic. You get the funding in a well thought out proposal. And now we're going to hit the ground running, looking at 100% attachment with happy providers in our team. So I really think we're well on our way with our PCN action plan and dyad leadership and this multidisciplinary approach with trusted partners. And I think I'm on to my last slide, if I'm not mistaken, at 11:58. Call your friends, make new friends. One is silver, one is gold. And it within the Raise Your Practice, start with that coalition of the willing, build from there. Probably we've all been doing that through our careers in primary care leadership. Show that return on investment, and that has to be early and future looking. Keep that excellent leadership employed and fully engaged. Be deliberate with words and clear in your definitions. Again, Colleen in small group, that resonates with me so much. We have to define both locally and then reflect what does that look like for our patients? What are they hearing about what the work we're doing? And what does OH think we're doing? So you've got these multiple audiences. You have to go back and in your deliberate, clear way say, here's how primary care is initiated and acted for our people, by our people, and be genuine about co-design.
Wonderful, thank you. Let's go to the next slide. So I'm supposed to do a teach back, but I can't possibly do justice to the work that Kim and Lori have talked about in 1 minute. What I do want to do is get you set up for the peer problem solving session next week. We're going to come together and talk about these staging issues. The one thing I will say in sort of summary is that there needs to be a clear vision of what it is you're doing, and you need to stick to the vision. Or if you have to divert from it, make sure you alter the vision and mission. That is something that I think gets lost in a lot of the project work. So when you're thinking about staging, a good vision is where you start. And then from that point on, the work that you do has to be tied directly to your vision. Please be prepared to share on all the following your approach to how you're staging the work next week, questions that you might have, and how you're overcoming challenges. Kim and Lori will be there. And then just, I think there's one last slide, is there not? Yes, so the same questions that I mentioned earlier. Think about these questions before you come next week. Rob?
I just wanted to congratulate Kuching again on this. They've been very deliberate, very thoughtful around how they're developing their work over many years, and clearly continue to go back and build trust and so forth. The thing that they did that I think is just remarkably important is building leadership capacity in that dyad leadership, and have focused on that, particularly for PCNs. And that, I think, has been one of the deliberate reasons that you've been so successful at this, Lori and Kim. It's a really important fabric, and we'll be talking.
Rob is up in the north, so it looks like he's lost his internet. Kim and Lori, thank you so much. We look forward to seeing you next week. We lost you there, Rob, but I think we got the sense of what you were saying. So we will see you all next week. Thank you for taking time today, and have a good rest of your week.